Great, thank you, and thank you everyone for being here. And definitely please feel free to interrupt. Breast cancer is a huge topic, and so I've chosen to focus on new things that are on the horizon, but there certainly is a lot to talk about just in terms of standard of care that I'll just touch on. But if you have any questions related to that as well, please feel free to ask it now, during, or at the end. Any time is fine. So what do today and tomorrow hold for breast cancer treatment? And we've made some progress over the years. So on this graph on your left, it's a little bit hard to see, and this picture is on your handout as well. That handout is meant to serve as kind of an outline with the key points of what I'll be talking about tonight, and hopefully will also give you something to take home to refer to. Sometimes I go a little bit fast, let me know if I need to slow down, but sometimes it's just nice to look back if something were to come up in the future and have that as a reference. So mortality or death from breast cancer has improved over the past few decades from 33 people per 100,000 in 1989 down to 20 people per 100,000 in 2015. So a slow, steady decrease, which is what you can see on this graph coming down here. So this downward trend for breast cancer, which is really exciting. We want that to continue down and get to zero, hopefully as soon as possible, sooner than later. And if we look at the map, that shows by country what breast cancer survival is at 5 years after diagnosis. And so the darker the blue, the better the outcomes. And North America is in the 80+% range, meaning most women diagnosed with breast cancer are survivors. And part of the reason for that is access to health care, early screening for breast cancer, early detection. Typically, the earlier we find the breast cancer, the higher the cure rates are for it. Whereas if you look at some less developed countries, more to that light teal range, where it's down around the 50% range. So that means women in those countries, their breast cancers aren't being found until they're very far advanced. The access to care, the availability of different drugs, medications, surgeries, radiation therapy is much more limited. Breast cancer has been around for a very long time. It was first mentioned, written on papyrus over 3,500 years ago, when a physician back in that day and age described it as a bulging tumor in the breast and said there is no cure. Once it's there, there's no way to get rid of it for good. And Hippocrates, who's really the father of our modern medicine, although it was back in the BC era, even then, at that point they used terms like black bile and humoral disease, and so that's what he used to describe it, saying it's due to an excess of black bile, meaning the body was out of its kind of out of whack, off its equilibrium. But once you had that excess, again, it couldn't be cured. And now we know over 80% of women in the US, if we look at breast cancer as a whole, can be cured from breast cancer. But after Hippocrates, the next 2,000 years, it was thought to be a systemic disease, meaning once it was found, it was already all throughout the body, and there's no way to get rid of it for good. And surgery, therefore, was rarely considered. They thought it wouldn't do any good to remove the breast or remove the tumor if it was already all the way throughout the body. But we've since learned that that is very inaccurate, that breast cancer does often progress very methodically from a very small abnormal area that can be cured, and only if left alone or if resistant to treatments can it become a systemic disease that can be difficult to cure. So this image is from the Realism era, which is a painting by Rubens of the Three Graces. And if we focus in on the woman on the far right, you can see some changes in her left breast, or our right side of the screen, compared to the other side. So the left breast is smaller compared to the right. There's some redness of the skin in this area here. This nipple's pulled in compared to the other side. Up in this area here, it looks like there's an open area of the skin, an ulcer, and then some bulging in this area here, those lymph nodes under the arm. And those are all signs of a more advanced breast cancer. And so in that era, they drew people as they were, and he drew this woman with the breast cancer. So how does breast cancer present? How do you know you have breast cancer? And often you don't, that it's asymptomatic. You aren't aware that there's anything going on. And that's why we recommend screening mammograms to come in and have the breast checked. The earliest stage of breast cancer is a non-invasive breast cancer, or really a pre-breast cancer, most commonly DCIS, or ductal carcinoma in situ. And typically that's asymptomatic. Over 95% of the time you don't feel a mass with that, and the cure rates are over 95%. It's not life-threatening because it doesn't have the ability to travel throughout the body. If breast cancer has broken out of those ducts, it's more likely to form a lump. It still doesn't always. Sometimes you can't feel anything in the breast, but of course feeling a painless lump is one of the more common things that women come in with who are diagnosed. In men as well, there's about 1,700 men per year in the United States who develop breast cancer. There can be some swelling under the arm or a lump under the arm like we saw in that image. And less commonly, somebody might describe, my breast just feels very heavy, or I have pain in my breast. Often that's not breast cancer, but it could be. So if it's a persistent symptom, you still need to come in and get that evaluated. There can be some changes of the skin, some swelling or thickening of the skin, or redness of the skin. The nipple, as we saw in the image, could be pulled in, but it also could have some discharge, especially bloody discharge is something that should be checked out. And as I said, anything that's persistent in the breast that's not normal for you is in need of an evaluation. So I have a few images. This is a breast cancer here in this, just above the nipple and areola. And the skin is a bit red. And if you could do an exam, you would feel a lump here about the size of a golf ball sitting, and then there's some redness over top of that lump because it's putting some pressure on the breast and affecting the blood flow and the lymphatic flow. This is an example of a breast cancer that grew and eroded through the skin and deformed that bottom part of the breast, and could be misdiagnosed as an infection or an abscess or something like that. And then this is a breast cancer that was left unaddressed. So we do unfortunately see it here in the United States, but where those cure rates are closer to 50%, a presentation like this is much more common. So at this point, it's a lower chance of cure compared to finding something just on a mammogram. So if you're not sure what's going on, don't ignore it. If one doctor tells you it's nothing, seek another opinion, and especially to get a biopsy and understand what's going on. So I don't do those to startle you, but just to show you some different ways that the breast can look with breast cancer. So treatments for breast cancer are local, meaning if looking at treatments for the breast and the lymph node areas, surgery and radiation are the two main modalities in there. And that's the surgeon or the surgical oncologist, the radiation oncologist directing those treatments. And then the systemic therapy is the medical oncologist. And when we think of systemic therapy, I think most often our mind goes to chemotherapy, which is one option. But in breast cancer specifically, there's other options as well, depending on the type of breast cancer that somebody has. There's endocrine, or it's really an anti-endocrine pill form of therapy. And then there's other pill form or IV targeted agents such as immunotherapy or biologic therapy. So when we say see the medical oncologist, don't jump right to that means I need chemotherapy. It may mean that there's different medications that might be right for that breast cancer. So I'm going to focus on some of the new things on the horizon for each of these. And again, it's just a small sampling of a very big topic, but hopefully this will give you some information about what's on the cutting edge in some of these areas. So systemic therapy, I think, is a really exciting area in that back from, as I said, that history of breast cancer, it was thought every breast cancer was the same. None was curable. It was all throughout the body. And we started to learn a little bit more about it. There are different kinds, started in different areas, they behaved in different ways. And one of the first things that was learned for breast cancer was something called ER, or the estrogen receptor, and that was really identified in the 1970s, but it wasn't until much later that we had a treatment to direct against that receptor. And let's see, so that brings us into by 2000, we were able to separate breast cancer into 4 main different subgroups. There is an estrogen and progesterone rich, there was ones without estrogen and progesterone, and then a third receptor called HER2 So you might hear triple positive breast cancer, meaning all of those receptors are present, or triple negative, meaning they're all absent, or you can have a combination of the two. And that helped us guide therapy. If you don't have the estrogen receptor, that endocrine therapy will not be helpful for you. So you don't need a medication that will just give you side effects or a potential for side effects, but doesn't have the ability to treat the cancer that's there. And then beyond 2000, we started to look more into the genetic makeup of the tumor itself. And that's at this box here, these gene expression-based prognostic signatures. So that's a big way of saying they look at the genetic makeup of the tumor and what genes are there. Are they genes that make it more likely that it tells us about the biology of the cancer. So is this particular cancer one that has the biologic ability to spread throughout the body, or is it one that's more likely to stay put? Is it one that might stay quiescent for a number of years, or one that we expect to see continuing to evolve and mutate and grow very rapidly? And then over the more recent years, it's rather than looking for these specific genes, it's starting to sequence the entire tumor and understanding very specifically what are the mutations for any one tumor and what therapies, what kind of special concoction for each individual person and each individual tumor would be most beneficial. So we're just on the brink of that there. That's not quite standard of care, but that's where the research studies are being designed around at this time. So this goes from those 4 main subgroups of the receptors to now saying based on the gene, based on the DNA makeup, if you have a certain mutation, you get a certain targeted therapy. This is a pictorial example of those receptors because I think they can be a little hard to visualize. So here we have a breast cancer cell, and these yellow geometric shapes are the estrogen receptors, and then the blue balls are the estrogen in the body. So if that breast cancer cell has an estrogen receptor, then it has these floating around, and if the estrogen in your body binds to it, it signals the DNA to increase the growth of that breast cancer cell. So there's a medication that essentially blocks the interaction of that estrogen with the receptor so that it can't signal the cell to grow. There's also one called the progesterone receptor that works in a very similar way. And then the HER2/neu receptor, the normal breast cancer cell has some of these receptors. They're a natural part of the breast cancer cell, and that is part of signaling the breast tissue to grow and be healthy and do its role in the body. But there can be a proliferation or an overproduction, and that can signal the cell to start to divide too much and to become abnormal. And so with this receptor, there's some targeted agents that are through an IV. The 2 currently out are trastuzumab or Herceptin and pertuzumab or Perjeta. Perjeta's been out for approximately the past 5 years or so, and when those 2 work together, if they're given at initial diagnosis, they have an over 60% chance of no disease detected after receiving those at the time of surgery. So they're very effective against that type of tumor cell. But if you don't have that receptor, that medication doesn't do you any good. So it's important that we recognize this. And that's standard of care right now. What's the next step is to further subdivide even more. And this chart, I don't think this one's on your paper, but it's just a summary of looking at these receptors that tells us of the prognosis. Is it good? Is it intermediate? Is it poor? What's the treatment? And then these are some of the genes that go along with those receptors. So going to the next step of starting to understand the genetic makeup even more, this was a large study from the UK that looked at over 2,000 breast tumors and started to subdivide them based on their genetic makeup. And they found that when you use the presence or absence of those receptors in addition to the genetic makeup, there's at least 10 different subgroups instead of the 4 main ones that we characterize now. And a lot of that diversity was in the triple negative subgroup, that they can behave and act very differently. But even in the estrogen receptor positive, which are usually slower growing, more favorable breast cancers, there's a small portion of those that have a more aggressive biology. And so by subdividing those out, we can tailor treatment accordingly and escalate therapy in those that are biologically more aggressive and just as importantly, de-escalate therapy in those that are calmer, less aggressive tumors that might not need every therapy that we're currently giving.
Triple negative is a little more aggressive than HER2?
Compared to HER2, it also depends on the estrogen and the progesterone status. But in general, the triple negative breast cancer subtype tends to recur most quickly, and it has currently the least number of options because it doesn't respond to the HER2 therapy or to the endocrine therapy. So it seems to be perhaps more aggressive because we don't have as many treatment options for it. But that may very well change in the near future as we're understanding more and more of their makeup.
Recurring though, once they get it all, do you find that that's one that can come back if they get it all?
It's a hard question to answer in terms of there's no current test right now, which is a big frustration for all of us, that we don't know for sure that every cell is gone for good. And so you go through these treatments and there's no way to know at the end, yes, everything's absolutely good, or no, there's still something lingering and I need to be more careful than the next person. But we do know that there's patterns of recurrence. So triple negative breast cancers are most likely to come back more quickly. So their highest risk period is in the first 2 years, whereas the estrogen and progesterone positive are more notorious for coming back a bit later. So within the first 5 years, or even a subgroup of them beyond 5 years. So difference in that, it's hard to say, does that mean more aggressive or not? You could end up with a cure or not a cure either way, but the timing of it, that risk period of recurrence varies between the two. And so the next step on that timeline were these multi-gene assays, so looking at not only the receptor status, but the genetic makeup of the tumor. And most of these advances have been in the ER/PR positive population, with that triple negative, because of its larger diversity, being a little bit further behind. And there's a number of them: EndoPredict, MammaPrint, Oncotype DX, PAM50. Those are probably the more common ones that are used. And each of these looks at a set of genes ranging from 2 genes to 97 genes. And these are used to help us direct therapy. So one example is for Oncotype. It looks at 21 genes that are present in the tumor, not in the person, and then comes back with a number based on the myriad of genes that are present or absent. And so looking at that graph, so the score is 44, and this is broken down. Less than 18 is low risk, 18 to 30 is intermediate, and greater than 30 is high risk. So 44 is the high risk category. And then this graph says that based on this genetic makeup, what the likelihood would be if somebody took endocrine therapy alone, in this case tamoxifen, the distant recurrence rate would be about 20–25% with just the endocrine therapy. If chemotherapy was added in addition to the endocrine therapy, that would drop to about 7%. And so based on this, you could make a decision, is that difference in risk reduction worth it for me or not? And that's going to be a different answer for each different person, both in terms of the magnitude of that benefit as well as what are the possible side effects. For a low score, for a score less than 18, that difference is about 1 or 2% in many cases. And for most people, and the physicians typically don't recommend chemotherapy because the margin of difference is so small. Whereas previously, everybody with this type of tumor would say, you need chemotherapy, you need endocrine therapy. Now we can say, this is the amount that we think that based on the genetic makeup, this treatment may benefit you, and have a conversation for what's best for you. Another one is the EndoPredict, which answers a different question. So this is for ER/PR positive tumors in terms of the recurrence, when it might recur. And so there's different genes that are present or absent to predict that this is one that might recur in the first 5 years versus this is one that might recur in years 5 to 10. And that's important because the current standard has been to take endocrine therapy for 5 years. There's some newer data suggesting that 10 years might be better than 5 years, but that endocrine therapy can have some side effects. There are often menopausal-like symptoms, and so you don't want to take it for another 5 years if it's not going to benefit you. So this type of test can help determine, is this tumor one that 5 years might be sufficient, or that I might benefit from staying on for another 5 years? And so this is a summary slide of a tumor cell that has all these different color-coded here genetic mutations, and where researchers are identifying those and, most importantly, coming up with targeted agents for those. So if that mutation is present, then this drug would work against that, with the goal of, there's a breast cancer, there's breast cancer, everybody in this group has it, but we know it's not the same. And so by identifying those differences in that, the tumor makeup as well as the person, that therapy can then be targeted based on that individual, what's going to best help that individual. And the biggest trial that's doing this right now is through the NCI, or the National Cancer Institute, which is not for first-line therapy. This is on the edge, so it's first looked at. New therapies are usually looked at in refractory or metastatic settings. But this is taking the tissue from the biopsy or the surgery and doing a sequencing of the genetic makeup of the tumor and identifying all the different genes or mutated genes that are there. And it's for breast cancer, but also for some other types of tumors. And I know this is too small to read, and it's just one section. Their list goes on. But that if you have it, for example, an EGFR mutation on the top is A, then you would get this drug, afatinib. And if you have this C2 arm, if you have the MET X14, then you would try this drug. And so these are new options that are coming through that might be like this combination of the Herceptin and the Perjeta, where now our complete response rates are over 60% in a breast cancer that before was minimally responsive to the traditional chemotherapy. And this type of trial will give us information for moving this further into the first line, so that our prediction is over the next 10, 20 years, the recipe for one person is going to be very individualized and very distinct. We do that already to some extent, but it will be becoming more and more fine-tuned over time. Some of the challenges of why we can't get rid of every breast cancer all the time. And cancer cells mutate. Things that grow quickly, they don't go through the regular checks and balances process. And so they end up with a lot of errors in their DNA. And that can change a cell from what looked like a certain thing at the beginning to something else down the road. And so there's two types of heterogeneity that are difficult to overcome when you're working for cancer therapies. One is called spatial heterogeneity. So in this example here, this is say a breast cancer. And each of these color balls, it all came from the breast tissue, but each of these has a little bit different genetic makeup. And so each of these is going to grow and continue to divide and form new cells. And if we have a therapy that, let's say we sampled this green and orange here, and we have therapies that are directed against those, we might wipe out these progeny completely. But if we don't have a treatment, or if we didn't recognize that there is also this mutation that's in that blue one, that is the one that could continue to develop and cause problems down the road. So by sampling a tumor, either biopsy or even with surgery, there's a lot of, it's a very eclectic population in there. The second is that over time, the tumor can mutate. So it might start off as this one cell here, and it divides into two. And then when this one divides into two, it gets some new mutations that are different from when this one divides into two. And as that keeps happening over time, again, you might have therapies that take care of all of this, but this cell line now looks quite a bit different from the initial one. And that's successful again, in the United States, 80+% of the time. So we're doing a good job, but we want to be doing a complete job. So then switching gears into talking about just one topic, or one or two topics each for surgery and radiation, new things that are on the horizon. In terms of surgery, there's surgery that's on the breast, so a lumpectomy, removing just part of the breast where the tumor was, or a mastectomy, removing the entire breast. But there's also surgery to consider on the lymph node system. And so this is a picture of the lymphatic system in the breast there in blue. And it's this plumbing system of the breast that helps the body fight infection and helps cleanse the body, keep it clean. And during invasive breast cancer can get into that lymphatic system and use that as a way to spread throughout the body. It usually spreads methodically, and so during surgery for an invasive breast cancer, that underarm is usually sampled to see if there's any cancer cells that have made it from the breast to this area here. And if there's no tumor cells visible under the microscope, then it's a very small chance that there's any cancer that has invaded into the lymphatic system, and we would consider that node negative. Versus when they sample it and there's a small amount of cancer there, even if it's microscopic, we then worry that it might have infiltrated even further in this system. So before we had a way to sample those lymph nodes, the surgeon at the time of the breast surgery would remove all of these lymph nodes under the arm here, and that would create a risk for swelling of the arm called lymphedema. Over time, we realized that by sampling the lymph nodes with a procedure called a sentinel lymph node biopsy, where they just take out the first station lymph nodes, we can avoid removing all of that tissue, called an axillary lymph node dissection, in a lot of women, and decreasing this risk. But when we radiate, if there's lymph nodes that are involved, or if it's a large tumor or some aggressive features, we sometimes need to radiate those lymphatic areas as well, which can cause scarring, which can also create a risk of swelling of the arm. So surgeons have been looking at a way to, both as prevention or as treatment for lymphedema of the arm. And there's 2 new procedures that are being done at some centers throughout the country that are showing some promising results, although it's still some very early data. So this first one is called a lymphovenous bypass. So kind of like a congested highway, you need to alter that flow of traffic. So the green here is the lymphatic vessel, and this would be its normal caliber out here, this kind of nice skinny green vessel here. And here's where the lymphatic flow, it's scarred, or the stations have been removed from surgery, so it's thicker and it gets congested, and that makes the arm swell. So the blue here is the blood vessel. So the surgeon can cut this lymphatic channel where it's not draining and instead have it drain into the vessel to bypass that congested area. And this on the far end is an example of it in real life in the operating room. So the lymphatic vessel here coming into the blood vessel there. And that's really magnified. They do this with a microscope. It's a microvascular technique.
They can do that now, like if your arm is swelling, so that can be done now, even if you had the cancer a while back, but you have the
Correct.
lymphedema, that can be done now possibly.
Possibly right. They have certain indications, and it's been studied more in some scenarios than others. But yes, I think this is something that if you or somebody you know is affected by it, to talk with a surgeon who does it to understand exactly who the best results might be seen in. And then the second way to help surgically with lymphedema is, rather than bypassing it, is to move in some new, fresh, unaffected lymph nodes. So this is a little bit bigger surgery, and you have to take healthy lymph nodes from somewhere else. And there's multiple options, but the most common is to take them from the groin and transfer them up into that underarm area. And so this is a schematic, but then this is an example of looking at the groin. This is fat, and this is blood vessel coming in, and then the lymph nodes in there. And what they do is they take blood supply with this fat and lymph nodes here, and they transfer all of that up into the underarm area to give it fresh new avenues to route through. So again, there are techniques done they're becoming more and more in use, and there's a little bit of randomized data for them, but they're still on the horizon. So they're not standard of care for a breast cancer surgery. This is not being done for every person all the time. It's not the picture, but the information, yeah. But feel free to take a picture too. And then this is an interesting concept that's in a phase 2 study, meaning still a understanding if it would be an effective approach. And this is for breast cancers that required systemic therapy up front, so chemotherapy or that targeted biologic therapy, and they shrunk down a lot with those initial months of therapy. right now, everybody still needs surgery on the breast, but anywhere from 30 to 60% of the time, there's nothing left in the breast when they look under the microscope after surgery. So this study is looking at giving chemotherapy first. If the imaging looks like the tumor's gone away, then doing a biopsy of the area where it was. In this study, you still go to surgery, and they compare how accurate was the biopsy to what they're finding at surgery. If there's a good correlation between those, the next study would be probably randomized between having surgery or just having the biopsy, with the thought that it's very likely that in people who respond well and have a negative biopsy, they might not need the lumpectomy at all. Radiation would likely still be recommended, but you might avoid surgery, and therefore the effects of that on the breast, sensation, cosmesis, risk of arm swelling, things like that. And then my third topic, radiation therapy. And these graphs are too small to see, but this is the difference in survival with using radiation. So about a 5% survival benefit when radiation is used for many breast cancers. And this is the difference in local recurrence. So about a 20 to 30% decrease in local recurrence when radiation is used just after a lumpectomy, just removing part of the breast. And there are several ways we can deliver the radiation. So most commonly is with a linear accelerator that delivers photon or X-ray radiation. And this is a diagram of the beam profile. So the radiation beam goes into the body, deposits most of its dose at a shallow depth, and then exits all the way through the body. And so we use higher energy beams or multiple beams to get this dose deeper if we're treating a deeper area. And it works very well for many types of cancers, but this exit dose, the fact that it keeps going on, can be problematic for certain areas that we treat. So proton therapy works a little bit differently. It has a similar type of machine, but it's called a cyclotron. It's delivered the same way from outside the body. There's no radiation that stays in you, and nothing invasive to deliver the radiation. But its beam profile is a little bit different. So everybody can, better off pointing on this one here. But it goes, you have some dose along the entrance, and then it deposits most of its dose further along the beam path where the tumor is. But the most important thing about it is then the dose stops. So all of the dose is absorbed in the body, and there's no exit dose. So you're able to avoid all of the tissue that sits adjacent to it from receiving any low-dose radiation as it exits the body. So in breast cancer, where that can be most beneficial is when we're treating the left side, because the heart, although it's in the middle of the body, it sits more off to the left, especially when we need to treat the lymph nodes that sit along the breastbone called the internal mammary nodes. And here's some pictures here. This is a CT scan with the heart in the middle, the lung is black, and the color is the radiation dose. And so with proton therapy, we come in from the front, we treat that entire length and width of the breast, and then the dose stops. So we're avoiding the heart here to a large extent in the lung, with just a little bit of that front edge right where the breastbone is, getting a little bit of radiation. And then on the profile view here, we don't have any radiation exiting out the back, and there's a little bit of dose to the lung up top where the lymph nodes sit very close to the lung, but we're able to stop that radiation dose right along that front edge of the heart. And that's compared to X-ray radiation, which we use that through and through effect, the in and out effect, by treating sideways across the breast, like the arrows show you here. We wouldn't want to treat the breast coming from the front, because then we'd have all of that dose, the full dose, exiting through the heart and lung. So even with the X-ray radiation, the risk to the heart and lung is low. It's 5% or less, but we use that through and through effect by treating at an angle. And up here where we treat the lymph nodes around the collarbone, you can see how the dose exits all the way through the body compared to stopping behind this pink target here. And then down along the heart, most of the heart doesn't receive radiation, but that front edge can still receive some of that low dose. When we treat across the sides like this, it's that front edge of the heart that can get clipped in the beam. And we have some different techniques to minimize that, but depending on somebody's anatomy and the areas that need radiation, we have more or less ability to protect the heart and lung. So the proton therapy can come into play to be very helpful, especially in those more technically difficult situations.
Well, this is coming. I mean, well, it's here, but like insurance companies might not maybe let you do
Correct.
this right now because it's so new, even though it's really the best.
It's a great question. And so the Proton Center here at the University of Florida has been open for 12 years now, and we started treating breast cancer about 6 years ago. So it wasn't one of the earliest things that we treated for a few reasons. One, insurance, but two, because the breast is on the outer part of the body, it was initially thought maybe there's not as much advantage as to something buried deep in the body, such as a brain tumor or something deep in the pelvis. But as we gain more experience with it and we're able to expand our understanding and application of it, we found that it does an excellent job of protecting the heart and a very good job of protecting the lung. It is a more expensive treatment in most cases, and so insurance companies can be reluctant to cover. So I was talking with somebody beforehand, it's a little bit of a chicken and the egg. The insurance companies want proof that it works, but to develop that proof, you have to be able to treat people. So I think there's little argument that the computer modeling is better, but what does that translate to in terms of objective difference in side effects? That question is still unanswered. There is a randomized study that's now open throughout the country that we're participating in that for left or right-sided breast cancer where the lymph nodes, there's an indication to treat the lymph nodes. It's a flip of a coin study, a flip of a coin that you're treated with x-rays or treated with protons, with the primary endpoint being the 10-year risk of having an injury to the heart. And it's a very large trial with almost 2,000 women. Because that rate of heart injury is so low, it needs to be a large number of people to really measure if there's a difference. And that, depending on the results of that study, it might help the insurance company. The trouble is that answer will be a ways down the road, and we might very well will have new, different technology that surpasses this at that point. There are a good number of insurance companies that will cover, and if we think that it's the best thing for a person, we go to extreme measures to try and make that happen. Everybody with breast cancer does not need proton therapy. In many cases, the traditional X-ray therapy does a very good job. The effectiveness between the two for breast cancer is the same. It's the same dose of radiation. So it's often we'll do comparison plans to help us determine for any one person, is there an advantage to using a more expensive therapy? We don't want to use something that's more expensive, more costly, if there's not going to be a perceived benefit for somebody. And then another small mention of radiation, this is a little bit further out. This is still in the laboratory studies, but it's a radiation sensitivity assay. So currently, we're a little bit behind the medical oncologists with radiation in terms of the dose that we use to treat breast cancer is very similar from person to person, yet we know that each of our genetic makeup is different, and some of us may be more sensitive to radiation, some less, as well as some breast cancer tumors might be more sensitive or less sensitive. And so there's some work being done across the country, including at Moffitt here in Florida, that's looking at the individual makeup of people and tumors to develop these assays. So similar to that Oncotype or that EndoPredict, what is this genetic makeup and how much would you benefit from chemotherapy? What is this genetic makeup, and do you need less radiation dose or more radiation dose than the person sitting next to you? So I think, I don't know the time frame, 10 years or so, I think that this will become part of our, has a good chance of becoming part of our standard approach when we're evaluating somebody for the benefit of radiation therapy. And as I think mentioned in the beginning, we want to cure breast cancer, but we also want quality of life and to keep lives as whole and wholesome and healthy after breast cancer as before. And so I think some of these things on the horizon will increase our ability to do that with this precision medicine, both in systemic therapy and also moving into surgery and radiation to really target for each individual and each tumor. We've already decreased the number of extensive underarm surgeries, and now we have some surgeries that may help fix that symptom if it does develop. The proton therapy for certain indications can help protect the heart and lung, And in general, just an increased awareness of survivorship needs, and we've seen this a lot in pediatrics as well. It used to be just enough to cure cancer, and that's great, you're alive, but more and more research has said, and with 3.5 million survivors in the US, that quality is extremely important. And so looking at our therapies and not giving therapies that are unnecessary, escalating or de-escalating appropriately, and listening and learning from people that have gone through this and what their quality of life is, so we can adjust treatments when possible to help maximize that. So this cartoon here says, I'm lying here permanently to reduce my risk of falling. So she has no quality, she's just laying there, but she's not gonna fall. And so we want to try to avoid that type of situation. So I have these listed on the handouts too. These are some good resources both for information. So the NCI at cancer.gov is probably the most expansive site that has all types of cancer, including breast cancer. Good information with links to studies or literature about it. American Cancer Society, Susan G. Komen, Dana Foundation, both for information as well as for resources. And then this website here is a very long list of all different types of resources, including cleaning for a reason. So if you're undergoing treatment, this organization will come help you maintain your house, because that might be hard to do. As I mentioned, about 1,700 men per year are diagnosed with breast cancer and can often feel quite isolated because they're such a minority in this disease. And then groups for young women, women who are diagnosed while they're pregnant, specifically triple negative. And so I think that one website, really, if you have something very specific, as we're individualizing treatment and therapy, individualizing survivorship needs are also an important piece of this puzzle. So I appreciate your attention, and I'm happy to answer any questions. Yeah, that's a good way to describe it. And I didn't go into advances in imaging, and there are a few things on that horizon as well. So tomosynthesis is it's essentially a 3D mammogram. So they scroll through it more like they scroll through a CT scan, as opposed to just like a chest X-ray, a two-dimensional image. And the benefit of that is when the breast tissue is compressed, sometimes the normal glandular tissue can form a little ball, and you can't tell, is there something there? Is it just normal tissue? But when you can scroll through it, you get a better sense of that. So more and more insurance companies are starting to cover that. It was also kind of a chicken and the egg. Yeah, so should prove to us that it's better, but we have to use it to do that. So it's a very good option that can reduce the risk of, or reduce the need of coming back for getting called back on your mammogram. So there's thought to be less callbacks on your screening if they use tomosynthesis. Yes, so that is a classification system for all types of breast imaging. So they use it for mammogram, for MRI, for ultrasound, and it ranges from 0 is that it's incomplete. They couldn't get a good look at the tissue, but 1 is completely negative. It's uncommon to get a 1, it definitely is possible, but 2 is benign findings. So they see what looks like a cyst or what looks like normal calcifications in the breast. So BI-RADS 2 are very common, nothing to worry about. BI-RADS 3 we're not sure. We think it's okay, but we want to see you back a little bit sooner, usually 6 months instead of a year. 4 is that we're suspicious, you need a biopsy. 5 is highly suspicious, and then 6 is you've had a mammogram, it was abnormal, you had a biopsy, now you have an MRI. They already know that there's a cancer there, and that's what a 6 is. So that's kind of language for all of us, but especially for the radiologists to communicate to themselves and to others from year to year or from scan to scan what they're seeing in a very succinct summary. It's a really good question. Thank you.
Unusual questions. If you have a member that has had breast cancer, anyone who's had their cancer at any time, they say
So it can, and it can go both ways. So also very commonly now, standard of care is asking a family history as well as a personal history of other cancers, and then there's genetic testing that can be done with BRCA1 and 2 being the most common and most, the genetic mutation that we've known about for the longest amount of time that predisposes somebody to breast cancer. So there's certain indications for who needs genetic testing. We know that breast cancer is more common with age, so if you're typically over 60 with nobody else in the family with breast cancer, most likely it was sporadic and not related to any genetic preponderance to developing a breast cancer. But if you're 25 or 30 and you develop breast cancer, that's much more unusual, and it's more likely, it's not definite, but more likely that there's a genetic mutation that made it more likely for that breast cancer to develop. So genetic testing is something that's often discussed and recommended for certain indications and certain, and even the type of breast cancer, for example, triple negative, we recommend genetic testing for that a little bit different than for the ER/PR positive. So if you were to have one of those mutations, BRCA1 and 2 is the most well-known, one of the more common ones. There's other ones emerging. There's a PALB, there's a CHEK2, and it's a complicated arena because we're also identifying differences that this gene is different than the average, you can't say normal, but the most typical genetic makeup. But we don't know if it's a normal variant that means nothing or if it's something that could predispose you. So now on these tests, there's something, a VUS, or a variant of uncertain significance, which says we notice that this genetic makeup is different. We don't think it means anything based on our current data, but there's a record of it, and if this turns out to be something that we determine over time that it does put you at higher risk, then you would need some additional screening or have some additional measures. So in terms of if you have a genetic link to breast cancer, you may be more likely to develop other cancers as well. So there sometimes can be a link between, within the family of breast cancer and ovarian cancer, prostate cancer in men. Those can group together. There's some other syndromes that can be a breast cancer and a thyroid cancer. If you have radiation for cancer, it slightly increases your risk of developing a cancer related to the radiation. So that's something to be aware of as well. It has a huge benefit in getting rid of this cancer, but there's a less than 1% chance it contributes to a new cancer in that area in the future. So you could develop a second cancer from that in that way as well. Did that answer your question?
Okay. Working with your individual doctor about the types of cancer that may be common together.
Yes, correct.
Way of describing it?
So most breast cancers are sporadic, and it was bad luck, and you're not at a higher risk for other cancers and no other levels of concerns that need to be noted. That's true for the majority, but there are a small subset where, especially breast cancer diagnosed at a younger age, that you might have a little higher risk for other cancers associated.
Now that I'm 66, how often do you recommend mammograms? Because I was coming every year to get the mammograms, but last time I had one, the doctor said I may not need another one. But, you know, it's concerning. I just haven't heard recently. So.
There's been some controversy among the different advisory groups, but the favored approach is still annual, a once-a-year screening mammogram, really regardless of age, and longevity factors in. So if you're 85 and perfectly healthy and walking 2 miles every day, you should still be getting mammograms. If you're 50 and you just had a heart transplant and your kidneys are going bad, the mammogram's not the highest thing on your priority right now. So age is so relative, but we don't have any data that says, for example, pap smears have changed, and now with certain negative ones, you can go to every 2 to 3 years. There's currently no data to support that in breast cancer, so we still recommend once a year as long as your health is generally good. Yeah.
I just want to mention too, we get a lot of opinions, right? We hear things all over the place about preventive screening and how often to do it, and there's this financial tension about the costs, and all that's important as well. But I'm 61, and in my example, more than 10 years ago, I have very medications, they did biopsies. I was terrified, but I would have much rather have found it and known and been terrified and been told it wasn't cancer than to ignore it. So in my particular case, I would have been one of those people that they were talking about on the news. It didn't turn out to be cancer, thank God. But I'm a person who would rather know. So for me, preventive screening with a mammogram is a no-brainer because I would just rather know sooner, especially when I think about everything we were just told, where now there's so many options. There's so many ways to attack something that is a problem that didn't exist before. You know, I mean, breast cancer in many ways was a death sentence, and now it's not. So for me, knowing sooner is exactly what I want.
And the biggest risk factor is aging. So that's really the more common the older you get. It's one of the more common things that we see. So I don't think age should be a limiting factor.
Just kind of a twofold question. I had triple negative. I'm recently just out of 2 months, 3 months. And I had a bilateral. Do I even need to do a mammogram? Is the first question anymore because there's nothing there anymore?
Typically not.
Okay,
So
and then the preventive thing is, what do I go back and get checked for? Because you said things could come back, and since it's triple negative, maybe, you know, I need to be getting checked for, as she said, other things that might come back.
yeah, so typically after mastectomy, mammograms not needed. There are some newer surgical techniques or skin-sparing mastectomies, or if the surgeon's planning a reconstruction where they wanted to leave some extra tissue, sometimes those, we say the flaps, the residual there can be a bit thick, and there could be some breast tissue there. So in a small set of circumstances, mammogram could be considered after mastectomy, but typically no. But physical exam is the most important thing. So unfortunately, even after having the breast removed, even if you have radiation and systemic therapy, there's still a risk that it could come back. Often after mastectomy, a recurrence will be in the beginning, a small lump on the skin. So something might be scar tissue, so if you notice something, don't panic, but I would recommend going in to get checked out if you feel a new lump developing in that chest or in the underarm area. In addition to physical exam, when you follow up with your physicians, they'll ask you about certain symptoms. There can be some red flags in terms such as unexpected weight loss could be a sign that the cancer's come back. Pain, especially bone pain or pain that's waking you up from sleep at night. Headaches that are coming on a regular basis, also headaches in the middle of the night or early morning headaches that are coming. Those could be signs that there's something going on. There's many other causes for all of those, so it doesn't mean for sure, but those are indications that we would look further. Currently, our national guidelines do not recommend doing PET scans or CT scans on a regular basis to surveil like we do surveillance screening mammograms. It hasn't been proven that it's beneficial, but there also has not been many good studies on that. So I think on a case-by-case basis, depending on how things looked at the beginning, there are certain situations where we do think getting a PET scan at a 6-month or 1-year mark would be a good approach for certain people.
I have a family member that has that Barack.
Yes.
I
Okay.
don't know how much it is, but she was going to have a mastectomy elective. She's waiting to decide.
Okay.
But she started back smoking, and it scared me so much because I always hear, I mean, I know smoking isn't good for you in general, but isn't it really bad for someone that's got that Barack thing?
Smoking, yeah, smoking is bad on so many levels, cancer-related and non-cancer related. And some of the therapies, for example, in terms of that small risk of a second cancer after radiation to the breast, one of the highest risks are in people who are actively smoking because they also have a risk of lung cancer from smoking, and now you have this effect that's more than numerically additive. It also can limit the options. So for example, plastic surgeons don't like to do certain types of reconstructions in people who smoke because the blood supply isn't as good, it's not as healthy, and so that can limit your treatment options in that way as well. in terms of if a family member were to have or you found out that you had a mutation such as the BRCA1 or 2, your lifetime risk of breast cancer may be over 80%, whereas for the average person, it's about 13% over a lifetime. If your risk is 80%, some women will choose to have the breast removed preventively to prevent a breast cancer, and that can be a very good approach. If your risk is 13%, we don't recommend it because it's obviously a very extensive surgery that's life-altering, but for those high risk, it can make sense. You don't have to have your breast removed. There's also something called high-risk screening where in addition to mammograms, and your insurance company would pay for screening MRIs, and they're done on a more frequent basis so that if something were found, you again find it as early as possible. And there's also some medical treatments such as the treatments that are used to treat the estrogen progesterone positive breast cancers that can also be used to help prevent breast cancer. Although it helps prevent the estrogen progesterone ones, it wouldn't help prevent a triple negative breast cancer. Yes, ma'am.
40 years ago, I went to a physician and said, I have a problem with drinking caffeine. It swells up my breast. He laughed at me. But now I've heard research that says differently. Now, as far as the caffeine goes, what is the case? How does those cancer cells respond to caffeine and the swelling of the breast?
So current knowledge is that caffeine is not a risk factor for cancer development, but there is, we do now understand that caffeine can affect the breast tissue. So caffeine as well as chocolate can make the breast tissue more sensitive. And you can sometimes have sharp shooting pains in the breast or just feeling very full and heavy. And it's often asked when you go for your history with your doctor, how much do you drink, but there's no known association that's been proven, but it definitely can cause breast symptoms. So that's just something to be aware of. If you're having a lot of breast pain or heaviness, assess your chocolate and especially caffeine intake. And most people notice if they cut back that their breasts stop behaving that way. Yeah.
Like a balloon all the time.
Yeah.
And the next question would be, I haven't heard you mention anything about the integrated holistic approach to health through non-prescription drugs and other chemicals, like eating turmeric or utilizing herbs. So what's your take on that?
So there's two avenues of discussion. One is for cancer prevention. So what can be done diet and nutrition wise, or nutrition and exercise wise, to prevent all cancers or minimize the risk, including breast cancer. And then if you've been diagnosed with a breast cancer, what therapies are available that are, say, the holistic approach that can complement or some people use to substitute for the traditional means. So there's no easy answers to those for a variety of reasons, unfortunately. We do know that exercise is very helpful in minimizing the risk of cancer. It doesn't mean you could be a marathon runner and still get breast cancer. It doesn't guarantee it, but especially the estrogen and progesterone receptor positive, the more estrogen your body has, the more opportunity you have for any cancer cells to be fed by that estrogen. And early in life, the ovaries are the main source of estrogen, but after menopause, it's actually our fat cells that contribute to estrogen production. So being a healthy weight helps with maintaining lower estrogen levels. Exercise in general is going to, of course, help your weight and keep you at a healthy weight. It's going to keep your heart and lungs strong. So if you had to undergo therapy, you have more health of those organs going in. But we also know that diet and physical activity matter if we look at the incidence of breast cancer. For example, breast cancer is more common in Western countries compared to Eastern countries. So if you're an Asian woman living in Asia, your risk of breast cancer is much lower. Other cancers are higher, such as cancers of the nasopharynx or of the stomach due to our differences in food. But there's also studies that show that if you're an Asian woman and you move to the United States within a certain time period, approximately 10 years, your risk now becomes the same as somebody who was born and raised in the US, for example. So there's something about our environment and our diet that's that's making us more prone. Now, it's not the only thing, because breast cancer has been around forever, even before, you know, all of this. But we do see those differences globally, and so there are things that contribute, but exactly what those are, you can read on the internet, everything from A to Z, but there's no good science to support that. In terms of taking high supplement levels like antioxidants in general are very good. They protect the body from free radicals, which are, can damage the DNA, which can create a risk for a cell to mutate. But whether you get that through pill form or through a healthy diet, naturally through fruits and vegetables, there's no comparison studies to say that people who take lots of supplements or eat this diet have less. And I think it's because it's so multifactorial, not only of our environment and our diet, but our own genetic makeup. So I don't have a good answer, but I do think diet, exercise are important and they're relevant. We don't have a recipe for that yet.
One more question, if you don't mind. I keep hearing the word hormones. For those after menopause, your recommendation is don't take hormones or go and get some fat?
Thank you for having me clarify that. So hormone replacement therapy, which is taking estrogen and progesterone, typically after menopause or if you had your ovaries out at a young age for some reason, is generally not recommended. There's some medical situations where the benefits outweigh the risks, but it does increase the risk of breast cancer. That is something that's been proven. Typically, the longer you're on it, the higher your risk, and specifically it increases your risk for an estrogen and progesterone positive breast cancer. It doesn't increase your risk of a triple negative. When we say hormone therapy for breast cancer, it's actually an anti-hormone therapy, so it's taking that estrogen and progesterone blocker. There's a variety of them that work in slightly different ways, and that would be recommended if you've had an estrogen progesterone positive breast cancer, or if you have a high-risk genetic predisposition to it and you didn't want to have the breast removed, you could take that to reduce the risk of developing it. And then in terms of the second part of your question was holistic approaches after diagnosis of breast cancer, and that also has been diversely studied, but not really cohesively studied. So there's no study that randomizes non-traditional versus traditional approaches. And I do believe that they can be very complementary. I think you'll meet women who have gone through breast cancer who found acupuncture very helpful, who have found things like yoga and anti-inflammatory things like turmeric to be helpful. But we don't have really good science, and supplements or herbal medication or herbal pills you have to be careful with because they're not as well regulated by the FDA. So when you take a prescription medicine that's gone through the FDA, you know how much of each of those contents are in there, whereas over-the-counter supplements are not regulated, and what you think you might be taking may or may not actually be what's there. So it doesn't mean don't take it, but natural doesn't necessarily mean cure, and it doesn't necessarily mean healthy. All of our vitamins, for example, vitamin D, vitamin A, if you get too much of it, it can be toxic to the body. So too much of anything, is even a good thing, can be problematic.
Can you clarify the triple negative thing that you said about the hormone? You said it doesn't have anything to do with it?
It doesn't increase. So if you were on hormone replacement therapy, is that your question? Would it?
Yeah, well, I was on hormones from just a very young age, from endometriosis
Yeah.
up until I was older. I all the things, being healthy, ate healthy,
Yeah.
but still getting it and it not running in my family. I feel like it was from
The hormones.
the endometriosis or the hormones that I took from like age 15 to 50.
Yeah.
That's a lot.
So it would, if somebody had said I took hormone replacement therapy for 20 years, I'd say the most likely type of breast cancer you would develop would be a hormone-fed, hormone-sensitive breast cancer. So there's no way we can say it's not related with that, the diversity that we can see, but our general understanding is that it probably was unrelated, that taking those hormones didn't increase your risk of developing a triple negative breast cancer.
Presence of breast cancer, Santa Women, just
It's about 1 in 8 women. So just if you take all comers. And the median age of breast cancer is mid-60s, 65, 66 at the time of diagnosis. So, and that number really hasn't changed much over the years. Our incidence of breast cancers not going down, but the cure rates, the death from breast cancer is going down. So we're treating it better, but we haven't found a way to reduce its incidence. You can, by doing screening mammograms, you're going to find more and find them sooner, which is going to affect both. The incidence might look higher than it was, but your cure rate might look higher. So there's a little bit of a confounding factor there, but 1 in 8 women.
Progress that you're talking about, I guess, to look at the positive side of all this, rather than just be afraid of it, is that I've got a 25-year-old daughter. So in her lifetime, if technology and research continues at the pace, hopefully, if she had problems, the treatments and her outcomes are very positive.
I do think that's a correct statement. And even with the breast cancers that become metastatic, many of them are able to become a chronic disease instead of an immediate end to life. And so, for example, in estrogen progesterone positive breast cancer, somebody might live with metastatic disease for upwards of 5 years or even longer. Some of the others without the more directed treatments, we're not quite that far. So I think we're doing a better job of getting rid of it for good. When we can't, we have more options to prolong it and make it more akin to a diabetes where you're living with it, you need to treat it, but you're still living and going about your life. So I'm optimistic, and there's been probably some technologies that we never predicted that really change things. There's a lot of interest in vaccines, and certainly for something like cervical cancer that's directly caused by a virus in 95% of cases, I think we'll see an eradication of that for people who have access, and hopefully the whole world will have access in our lifetime. Breast cancer not associated with a virus and with this heterogeneity of it is going to be trickier, but I don't think it's impossible.
I'm just curious why do you make the first step down this route?
It's a good question. I was always interested in medicine, I guess, and I really like radiation oncology for a few reasons. One is it's a daily treatment for several weeks of, usually 4 to 6 weeks, and so you get to know people that you're caring for very well. And then we also see you in follow-up for a long time, and so develop relationships that really make life meaningful. I think it's such a privilege to walk with somebody through one of their hardest times in their life. And sometimes you don't have words to say to somebody, but just being with them can be helpful. And I think, when I have to walk through a hard road, I want somebody there with me, and to be that person for people has just been a huge blessing for me and has made my life such a different perspective, I think I have, than I would have if I took another road. I think being part of the workforce that's trying to get to this goal where our children won't have to be having these conversations is a really exciting challenge. And so the work that I'm doing on the proton side of things and the radiation side of things is a small piece, but if we all work on our small pieces, I think that puzzle will come together.
If you go through the chemo and things like that, in the beginning they say, but you were going to need radiation. But then in the end they say, okay, everything is good, you don't need it. But there's 50-50. Some will say you do, and some will say you don't. So it's your option. How do you choose in that particular situation where they say, okay, so the risk will outweigh the benefits in this case. So you don't need it, but in the beginning, you didn't need it.
So it can be, sometimes it's good to have options, sometimes it makes it really difficult to have options. And with all the data we have, we don't have an answer for for every specific setting. So we know kind of the extremes, that the most favorable, we can say we can de-escalate therapy, the most advanced that you need everything, and then there's these in between. And something like that graph that I showed with the tamoxifen with or without the chemotherapy, if you're reducing from 25% to 10%, maybe 75% of people would say, I'll do that, and 25% might say they wouldn't. And so when we're looking at radiation, there is a gray zone where there are some features that say this breast cancer is less likely to come back, and some features that say it's more likely. And weighing those, so do we end up with a 5% reduction in recurrence risk? Is that worth a 3% risk of a heart injury? And it's, all of those are unfortunately still estimates that without a crystal ball or perhaps these genetic markers that say, we know that your heart is not sensitive to radiation, but the tumor is, and we can give less dose, then that might make more sense, but we're not quite there. In addition, sometimes, especially if chemotherapy is given first and there's a very good response, there is data emerging like maybe we can cut back on surgery, maybe we can cut back on radiation in those cases because the systemic therapy is now doing more of the bulk of the work, so we can lighten up on some of the other therapies.
And you wouldn't have to go back later on, like later on down the line and say, okay, I'm going back for radiation now because I didn't get it before.
Typically not. If something were to come back, then it can be used in that setting, but if everything's looking good, then we wouldn't go back at that point to add it in.
I want to say thank you to Dr. Bradley.
Thank
This
you.
is really wonderful.
Thank you.